Hello everybody, this is Dr. Gokulraj, Head Department of Orthopaedics, Fortis, Vadapalani. Today we are going to discuss about the causes of knee pain. Knee pain as such is a common ailment for all individuals. So the most common cause of knee pain is, one thing, it could be because of the joint which is getting degenerated, which could occur in elderly individual. In younger individual, it could be because of the softening of the patella, otherwise called as the chondromalacia patella, wherein the cartilage which covers the joint becomes softened and it can produce pain. And the other causes could be because of the referred pain, which could be arising from the pain from the back, that is a pain from the lumbar spine can also produce this, as well as it can be a referred pain from the hip joint also. So a knee joint pain has to be evaluated. So the other causes of knee joint pain could be an infection, or it could be because of a tumor which could also arise at the knee joint. So the evaluation of a knee is basically a basic history has to be taken, the duration of the pain as well as the difficulties which the patient has because of the pain has to be assessed, and an examination of the knee joint has to be done, and further investigations like x-rays may be necessary to find out what could be the cause of pain in the knee. So the commonest, as I said, the commonest cause of knee pain is osteoarthritis. Osteoarthritis is nothing but the articular cartilage which covers the knee joint gets completely degenerated and it is lost, because the fluid movement which you get out of a joint is because of the cartilage. So if I have to use a model to show you that, so this blue portion is actually what an articular cartilage is. So if you look at it, so this is a very soft, and it gives you a fluid movement which occurs in the joint. And this soft portion, if it gets completely removed because of various causes, this produces osteoarthritis. So what happens, because this articular cartilage actually supports the joint, and the underlying bone is not designed to bear the weight, whereas the articular cartilage, being elastic in nature, is able to hold the weight and it is able to equally distribute it, whereas when the bone which is underneath is bit softer and it is made out of trabecular bone like that of a sponge. So when you start loading a spongy bone, it starts deforming. So that is why when you see patient with osteoarthritis, earlier ages they may have a straight knee, but what happens later, the knee starts bending either inwards or outwards, called as varus when it turns inwards, so your bone becomes like that, or it goes outwards, called as valgus. So these are the deformities which happen because of the osteoarthritis and the load bearing of the knee. So how do we treat this osteoarthritis? So osteoarthritis treatment basically is based on conservative management in the early stages. Conservative management in the early stage, I mean that it has to be treated with some painkillers, at the same time exercises. The exercises what we do is basically to strengthen the muscles of the thigh, the quadriceps, which is the front muscle, as well as the hamstring, which is the back muscle. So the strength of the quadriceps as well as the hamstring improves the knee joint function, and the patient, it will be able to offload the knee to an extent. So next is we give them the next stage of when the degeneration is much more than what it is. So we start them with physiotherapy, and if physiotherapy doesn't work, then we think in terms of giving injection into the knee joint. there are various types of injection which I'll be discussing later, and the final stage when the joint becomes completely, the articular cartilage is completely ebernated or it is completely lost and there is a lot of deformity, patient is unable to move or the patient is bedridden. In such cases you have to think in terms of doing a joint replacement. So joint replacement, as you know, what we do is, so this is a model which shows how a joint which is being replaced, and you have a metal portion which is used in the thigh region, the lower end of the thigh, whereas you have a metal portion which is used in the upper end of the leg portion, and you have something called as a polyethylene which is used as a bearing in this joint. So what articulates is the fluid movement which occurs after a knee replacement is because of this bearing which is made out of polyethylene. So this is what happens finally after a knee replacement is done. So there are various techniques of knee replacement, and I would like to talk about one particular technique, and this particular technique which is called as the kinematic hip replacement. So kinematic hip replacement is, otherwise it can be called as the personalized arthroplasty of the knee. So personalized arthroplasty, in other words, what it means, that in simple words, one size doesn't fit all. So that is what is the concept mainly at. So normally a knee which may be straight, as you look at it, the angle of the knee may be straight from the hip to the ankle. It may be it will be more or less in a straight line during the younger ages. But as the patient becomes, when the patient has osteoarthritis and the knee starts bending, so we need to correct the deformity. So deformity means the bend in the bone. So we are trying to correct the deformity. So if it is like this in varus, we are trying to correct it and straighten it. So by doing that, what we do in a kinematic knee replacement is, so the knee as such, you have, there are ligaments in the knee. So this is the lateral collateral ligament and this is the medial collateral ligament, as well as this is the quadriceps muscle and this is the patellar tendon which holds the knee into position, and this is the patella which is seen here. So this is the patella. So what is important in a knee replacement is we remove the meniscus as well as the anterior cruciate ligament, and in a kinematic knee replacement we take a cut in the bone here as well as in the back of the bone and replace it with an implant. So this is the implant which we use. So you put it inside. This is made out of a ceramicized metal. You put it inside. So by doing that, we are able to precisely find out how much amount of bone we cut, and we measure it every time. So if I have to cut this bone, I preoperatively decide how many mm of bone I am going to cut, and intraoperatively, that means during the surgery, I will be able to assure the amount of bone which is cut is equal to what I have measured earlier. So by that, I am confirming intraoperatively or inside the theater that what amount of bone I am removing, and the implant fixes in perfectly well. By doing that, I will not touch the ligaments which are there, the medial collateral ligament as well as the lateral collateral ligament and other ligaments within the knee joint. I don't even touch it. In a conventional knee replacement, these ligament needs to be released to put your prosthesis inside. Otherwise, you will not be able to put your prosthesis inside. So these ligament releases, the disadvantage of this ligament release is it takes a very long rehabilitation period for this patient to get back their original movement. So it takes a longer time for them to get back. Usually it takes about 2 months time for them to get back to normal routine. Whereas in a kinematic or a personalized knee replacement, because we don't touch the ligaments or we don't release the ligaments, what happens is it is advantageous to the patient because they are able to move much faster. The use of a knee brace, which we all normally, when we do a conventional technique of knee replacement, we try to give them a knee brace, which is like that of a cricket pad which they use. So like that you need to have, and you have to protect the knee, which is not necessary when you do an kinematic knee replacement or a personalized knee replacement. The other advantage is patient is able to can walk without a walker support initially, and a walker support may not be necessary till about a few days, because when we operate on both the knees, we allow walker support only for a few days, and then we remove the walker support, and patient is able to, when both the knees are done, the patient is able to walk without any aid or any walker support. So that is one more advantage. And patient, because there is no ligament release, patient is able to experience very less pain. At the same time, patient will be able to climb stairs much earlier when compared to the conventional knee replacement which we were doing in the past. So they'll be able to climb stairs within 2 to 3 weeks of surgery. They can climb stairs. So these are the advantage of doing an kinematic replacement. So in short, when we have to tell what is the advantage, so we try to bring back the knee which the patient was in her earlier stages. Whereas when she was about 30 or 35 years of age, we try to bring back the same position. At the same time, the knee will be put back into the same position which was about 30 years back. Suppose we do it for a 60-year-old patient, so they go back 30 years back, and we try to bring it back into that same position. So in other words, the knee will be exactly the same what it was earlier 30 years back. So what is the advantage for the patient point of view is, patient will be able to comfortably walk. They'll be able to do most of their activities without much pain, but certain things which you can't do is sitting in the floor, which we don't allow them to do. The rest of the activities they'll be able to do comfortably well, and much earlier they'll be able to rehabilitate faster. So that is about kinematic knee replacement. If you have any doubts or any concerns or any questions, you can always contact me. Thank you very much.